Before we begin, I wanted to offer a trigger warning. Since recording this episode, Dena has experienced a pregnancy loss. She's given us permission to share this conversation, and we are so grateful for her openness. But if you or somebody you love is navigating a loss like this, please know that you are not alone. Support is available, and we've added resources in our show notes and also a link to where you can support Dena's family during this time. Ever think, man, I wish I knew that sooner? Trust me, you're not the only one. I'm Alan Rose, and welcome to Learn Too Late. Hi, everybody. Welcome back to Learn Too Late. We are going to nerd out a little bit, which if you guys follow along, you know that I love everything science, and we are getting to talk to someone incredible today. Dena Goldberg is a genetics counselor, and if you follow along with the Pre-Vivor, if you follow along with my content, we talk a lot about being high risk. I carry a gene mutation. Dena, you have a family link, and I would love to be able to hear your story, talk a little bit more about what is a genetics counselor? What do you do? How can people access one? How are they helpful? So if you are somebody who carries a gene mutation, if you have a strong family history, if you are somebody going through IVF and you're interested in finding out what your genetic background looks like, would you talk to a gene counselor? So we're going to hop right in. I would love to have you introduce yourself and just let us know a little bit more about you and your life.
Absolutely. Well, yeah, I'm really excited to be talking to you and be part of what you've built. So I am Dena Goldberg, also known online as Dena DNA, and I am both a genetic counselor and a content creator because I was working in a clinic for many years and realized that so many people had no idea what genetic counseling was. And the only way to really reach as many people as possible was through different media interventions. So that's why I'm really focusing a lot on social media and then traditional media, and sharing what we're going to talk about today. So my background is that I actually became a genetic counselor because I have a little sister who has a chromosome abnormality, and my mom's a pediatrician, and she was really supportive of me going into genetics in a new way, in a novel way that I could really use my skills to help families that were like mine. And so I started this career thinking I was going to help families who had children with different disabilities, and that's kind of in the pediatric world. So that's a whole other space in genetic counseling. But then when I ended up graduating from undergrad, my first job right out of school was a breast cancer research lab where I was actually getting the donated mastectomy tissue from people who either had tumors or didn't, and getting preventative mastectomies and actually growing cell lines from those to understand how the cells became carcinogenic.
Okay, I have to interrupt you. This is so cool. And I think that anybody who's listening who has either a background in breast cancer or family history or anything, like, how amazing is that? How fun as a person who's interested in science to really be able to do that.
Yes, you would think it was fun, although I will say it was a lot of manual lab work and labor. And At the time I was like, you know what? I want to work with patients, not this tissue, right? Like, I don't want to go in the middle of the night at 2 a.m. and digest. I'm just like, I'm too social to be doing that. But it was a really great experience, right? Like, it was part of my journey, and it got me into the breast cancer space, just because it was the first job I got offered to get out to California from Illinois. So I took it and not knowing much about it. But yes, it was very interesting. I learned a lot, but it also, the main thing it taught me was that I wanted to talk to patients and not sit at a lab bench. Once I decided I wanted to see patients, I decided to go back to graduate school, and genetic counseling just made sense because it allows you to actually sit with families and get to know them and really help them navigate care. And then when I actually was studying for boards, I was like, oh, cancer is actually really, really, really interesting. But to understand how that affects a person and their family, to me, I feel like that's more interesting. And to me, it feels very satisfying to be able to help people immediately and to see the downstream effects of the help that I can give them. And so I worked for some telehealth companies. but also did a lot of media production to educate people about cancer genetics and other genetics in general. And then decided that I would open my own private practice so I could see patients on my own terms. And so, yeah, that's what I'm doing now. So I have a private practice. It's concierge, so it's all cash pay because I'm so sick of insurance and having to navigate their BS. And then I make content about this. So that's kind of my journey.
So she's beautiful and she's smart. I would love for you to explain what exactly a genetic counselor is and why do people not know you exist until they need you?
Yes. So a genetic counselor is an allied healthcare professional. So think of it as a member of a healthcare team. And we exist at most major medical centers and then many private practices, and also through telehealth as well, with different genetics clinics. And so we are actually embedded in many different specialties of healthcare. So there's, like I mentioned, the pediatric genetics, where a genetic counselor may work with a pediatric geneticist to help diagnose rare disease in children. There's a prenatal genetic counselor, which is how the field really started, and that's helping people understand their options for reproduction, but also when you're pregnant and there's abnormalities with the fetus, kind of counseling about that. And then there's now IVF genetic counselors who specialize in embryo genetics and help people make decisions based on their genetics of their embryos. And then, of course, the adult onset and preventative cases. So we have cancer, cardiovascular, there's mental health genetics, there's neurogenetics for early onset dementias and other neurological conditions. And what we do typically in all those areas is help patients and their families navigate a new diagnosis. We also help them get diagnosed, like if they're undiagnosed. And depending on the clinic, the team works a little bit differently, but we are really the ones that sit down with the patient for the longest amount of time, take a family history, help them understand their risk. And really the counseling part of our name is because we also are working on a lot of the psychology of helping you normalize this information into your family and your care plan, and helping you communicate the information with family members as well.
For the layman out there who might not know anything about genetics, having a gene mutation, people come to you when they find out, let's say they take a 23andMe test. They find out they carry BRCA. They say, oh my God, what do I do? What are the next steps for me? You're sort of the first line of defense of understanding what that mutation actually means. What would a normal meeting go like if someone said, okay, here I have this mutation. I know absolutely nothing about it. Help me.
Yeah, so I will say, so typically the way it works is that physicians will refer to us when someone's at risk. So they usually many times they have not yet had a genetic test. And so we do a full risk assessment to decide which test is most appropriate for them, because oftentimes the general testing may not be appropriate for every situation, especially with rare cancer types. Yeah, and there's a lot of many physicians are not trained in genetics, or maybe genetics wasn't as far along when they went to medical school. And also, by the way, genetics is changing literally every month. There's all these things to navigate, and understanding what the best test is, what genes are now known to be associated with which cancer types, and when we should start screening. So that's the reason that it's an entire field just dedicated to staying on top of that and making sure patients are up to date. And it is impossible and unfair for us to expect every physician to be also up to date on that, because they have a whole bunch of other things they're doing, which is really why we are the right hand when it comes to genetics of your healthcare provider, right? And just making sure that everything's up to date. So many times what will happen is someone will be referred just being high risk and they want to do the test, and we do a pre-test genetic counseling session. We talk about what it means to get tested, what it could look like, and oftentimes that actually alleviates anxiety down the line, because people understand more and they feel more in control of their choice to do a test, or their choice to delay a test or to not do a test. And so what's happening now is a lot of physicians will order the test and then send to a genetic counselor when someone's positive. And so that's kind of the second situation, which is similar to what you just asked about, right? Somebody gets a positive test, they want to know what's next. So In that situation, what we do is one, we want to confirm that the test was read correctly and that it was the right test. So when you talk about 23andMe or finding something on 23andMe or any direct to consumer test, we always want to validate it with a clinical grade test because 23andMe is pretty good, but there's other tests out there, especially with raw data. And using tools where you put your raw data in, there's a lot of false positives. So when someone comes to me with that, I'm like, first things first, we have to make sure that this is correct before you make any medical decisions on it, right? If it's a medical grade test already, or we do a test and it's positive, that's when we then move on to helping understand what the next steps are. So that usually will be dependent on which gene it is, because each gene is associated with different risks for different cancers and someone's known family history. So if we're lucky enough to have information on someone's family history, we integrate that with the genetic test results and their personal history as well, and really come up with a custom plan for them based on national guidelines and based on like my expertise of risk assessment, right?
I would love to know what is the biggest misconception that people have about your job where they're just shocked at this is something that you do.
Yeah, I think there's a few. I think in the cancer space, people think that genetic testing and genetic counseling are a luxury that only some people can afford or that only are offered to some people. And in the US, at least, it's mostly covered by insurance when people fit that criteria. And if not, there's a lot of financial aid, and paying out of pocket is like less than $200 in most cases to see a genetic counselor. And then the testing is usually around $250. So I think the biggest misconceptions are how expensive it is and that it's actually really doable financially. That's one. And the other, I think, misconception is like people think that genetics can tell you way more than it actually can or way less than it actually can. And so people either don't like really believe in it, that it's going to be helpful, or they're scared of it because they think that there's more information that we can get about them based on genetic testing that we do that's not actually real. So I think those are really the biggest misconception. Oh, and there's one more too. I think there's a big like myth that this information will be used against you for health insurance purposes, and at least in the U.S., there are laws that prevent that at both the state and federal level. Also, employment prevents genetic discrimination, and so there's a lot of support to really help prevent it and to be able to use this information in a way that helps patients, not that hurts them.
Do you see that as a possibility to change in the future? Because, you know, I don't want to get out my tinfoil hat, but with the way that the world is going right now, it's worrisome for people. And so I even did a pretty large panel consumer test that I had worked with this company, and they're based out of Hong Kong. And I'm like, well, I don't want a Hong Kong company to have my data linked to my name. I don't want the potential for, if I do carry a mutation that maybe I don't know about, to have that impact later on my ability to access life insurance, my ability to get insurance coverage. And obviously, while there may be protections now, that could always change. Do you have a lot of patients really concerned about that?
I think, yeah, definitely like more recently, just because of how volatile the government here is and just the state of the world is. I think I can't say it's impossible, right? Anything can happen. But I think we need to balance out the pros and cons of doing this type of testing. So the pro is really understanding what your risk is and learning how to get ahead of that risk. And if you have a high risk for having, like, let's say there's a family member with something like a BRCA1 or 2 mutation, then, and your risk is 50%, then knowing that information is going to be a lot more relevant to you and helpful to you than the risk of that happening, right? Of you being targeted for that information. And, you know, honestly, the risk of developing a cancer in a patient who is positive is going to be higher than the chance of like discrimination happening because of something. And so I think it's like, what is the benefit, the cost benefit to this? And in most cases, the likelihood of this information being helpful or even giving you peace of mind because you're negative that is much more likely than it being used against you in the future. The other thing to say about that is if you're only doing a cancer panel, let's say, and you're just looking at the genes associated with cancer risk, it's really not a lot of information. So it's not telling people like, oh, here's all these other diseases you might be at risk for, because it's sending the sample to a lab that is only looking at specific genes that are ordered. And there's about 20 to 30,000 genes in our genome. And we also don't really understand what many of them do. And so even though the genome has been mapped, it's not necessarily been fully interpreted. And there's a lot of other things that go into that. And so a cancer panel is not giving you the information, especially if negative, that can be used against you. It's not going to give, the companies that. And honestly, this is what I tell people. If you're going to be targeted by some nefarious place, there's a lot of ways to get your information. And if it's genetic information, which, by the way, is probably less helpful than like social media and internet footprints, by the way, because if you're going to be targeted for something or your habits or whatever, your social media and internet footprint is probably going to be more telling than any genetic information.
Yeah, that makes sense. Are you seeing more people in your practice specifically who are pre-gene testing or post-gene testing? So let's say somebody has, okay, my mom had breast cancer, my aunt had breast cancer, my dad's had prostate cancer. I think maybe I am at risk for BRCA. Are you seeing more of those patients or ones that say, hey, I have this and I want to know what I do next?
I definitely see both, a very good spread of both, especially because because I do social media and I am really involved in several patient groups. I will see people with both of those. And sometimes I see second opinions because somebody may have gotten their results from a physician and didn't have that like full genetic counseling session where they really got to ask lots of questions about it and go into, like I said, family communication and some of the psychosocial aspects of it. And so sometimes it's like more of a counseling session than it is a genetic counseling session, right? So I'm seeing a lot of those different situations, and I really like seeing all of those types of cases.
Yeah, that was my next question. Do you think that your practice leans more towards genetics or counseling? Are you really being the handhold to take people through this experience? Do you find yourself kind of filling that role as well?
Yes, absolutely. I think probably a big part of that is because when you work for a major system, like there's less time that you can spend with a patient because a lot of the insurance and the way that just the system works doesn't allow us to really sit for the long time. And in my personal opinion, I need at least an hour or more. So because I do like cash pay and it's just a bundle of sessions, it's 90 minutes, up to 90 minutes, which we don't always use, but we can if we need to. And I like it more because I can really get to the root of the biggest anxieties for each patient. And so, yeah, it's definitely a lot of counseling because I have the flexibility to be able to offer that. And I'm seeing less patients than I did when I worked in clinic, but I'm seeing them for longer amounts of time.
We mentioned that there are some people who think that maybe a gene panel or genetics test is going to tell them more about themselves or about the family tree. What's something that people assume would kind of show up in the family tree but doesn't?
Okay, so a lot of people will ask if I tested for Alzheimer's or if we tested for ancestry, right? And that's not, when we do a medical grade cancer panel, that's not looking at those things. So it just depends. In my practice, I do proactive testing. So I do more than just cancer. I'll do a full, it's like a genomic health screen where we're looking at really common conditions, cancer plus cardiovascular plus metabolic plus rare disease. So I do one of those, but it's still not looking at early onset Alzheimer's or some of the other conditions that people might assume are included. So that's why it's important when we do the pre-test counseling that people understand what tests they're choosing and what's on the test. The other thing I should mention is many times when people have done a carrier screen or they've done prenatal genetic testing, they think it includes things like BRCA or they think it includes cancer risk. And they don't understand that there's a big difference. And so sometimes people will say, well, I already had I already had genetic testing when I was pregnant, and I can guarantee you that you didn't have a cancer panel, at that point, because that's just not typically recommended at that point, or done at that point.
Right.
If you overlap, like ATM is on carrier screening, and it's also a cancer risk gene, but it's on carrier screening because when inherited from both parents, it causes a very different condition. So I think there's sometimes a little bit of confusion there, but I think that's something that I think that's like the most common thing I hear when it comes to, what people thought was tested.
Speaking of doing testing when you're pregnant, I'd love to talk a little bit about that because I see that as being the future of fertility. So I underwent IVF. I did PGTM testing. For people who don't know what that is, that's pre-implantation genetic testing, where I know that I'm a carrier of a certain chromosomal condition. I wanted to eliminate that from my family tree and eliminate any future carriers. So in my family, it's X-linked. 50% of my sons would be affected by this, and 50% of my daughters would carry this mutation the same way that I do. And carriers actually have an increased risk of cancer with my condition. So I wanted that sad family legacy to end with me. But now we're seeing more and more people who are undergoing, let's say, fertility treatments with IVF are doing these really large panel genetic screenings, and they test the entire genome of your embryo, which is incredible technology. So do you see that really being the future or becoming the standard for a lot of future pregnancies?
Okay, so I have my very strong opinions about genome testing and polygenic risk scores, which is what a lot of those companies are doing. I know they're doing polygenic risk, which I disagree with in embryos for a multitude of reasons. Are you familiar with polygenic risk?
I'm not.
Okay, so a lot of these companies are claiming that they're testing for things, but they're not testing. It's not the same as a panel where you're looking for the presence or absence of a mutation. It's looking at a bunch of little bookmarks along a genome that use an algorithm specific to that company that then says this embryo is like 2% more likely to have autism than this one, right? The problem with that is, imagine if you've ever done a test like 23andMe and you look at the trait reports, it'll say you're more likely based on the genes that they looked at to have a cleft or a dimple on your chin, or a widow's peak, right? And if you look at that, at least for me, half of it was incorrect because it's just looking at trends across a population. It's not looking at one gene that causes one thing. And so even in the cancer space, we use polygenic risk for people who aren't sure, maybe they don't have a single gene. We call it monogenic. So BRCA is a single gene that increases risk high enough that it would change behavior, or it would change our recommendations. But with polygenic, there's really no regulation because every lab has a different algorithm. So they're going to all get slightly different results. And it's only a few percentage higher. It's not like BRCA where you're like up in the, 60s to 80s, right? So, so what happens is there's really no long-term follow-up saying that this is helpful or that this is accurate. It's just a way to kind of rank these embryos, but there's a lot of things that aren't being tested. So I actually have a whole YouTube video on this and why I'm against polygenic risk scores in embryo testing. And then on top of that, it's one should be so lucky to have so many embryos that they can't decide which one to implant,
Right. So it's so funny. It's yeah, you've got people who have that one lucky one they're desperate for. And then I feel like you end up with people, I don't know, 25 embryos are going to test. And I mean, I know when I went through it, I had, 35 eggs or something, and I ended up with one viable embryo at the end of the day.
Right.
And people have this common misconception about IVF, oh, it's this easy way out, and oh, you just end up with all these embryos. No, you have all of these options, and that's just not the case. And I was very, very lucky that one healthy one is now my little 2-year-old, but that's just not it for a lot of people. And so when you're doing these testing experiences, it's very nerve-wracking, especially if you carry a genetic condition that you're trying to screen for.
Yeah. And I'm somebody who's very pro knowledge and information, but I think there is a line that you eventually cross when it is truly too much, and also not great interpretation of that information. So yeah, I guess if you want to learn more, there's that YouTube video I created about, it's called PRS testing in embryos. Um,
We'll add that in the show notes for anybody
yeah,
listening.
amazing. Yeah. I myself went through, a 4-year infertility journey, and I went through multiple rounds of IVF. Same thing as you. Like my first egg retrieval, I only ended up getting 2 embryos, and they were both genetically abnormal or aneuploid, so the wrong amount of chromosomal material. So then that was so depressing, and I was young, so it wasn't even like age related.
Right.
So I ended up doing another round a few months later, and I ended up getting 4 euploid or normal embryos. My first one I implanted took, but then miscarried, even though it was supposed to be this perfect embryo.
Mm-hmm.
And then the second one's my daughter. So it was like, it just, to me, it's like these other tests where you're trying to like optimize for IQ, which that's a whole nother story too.
Yeah,
That these
another moral
companies
and ethical dilemma we have here in the genetic
there's
space.
moral, ethical, but then also it's not accurate at all. And it's IQ is just one way to measure brain function. There's so many other ways, and so it's like it's very like one tiny piece of a giant puzzle, and you're making a decision based on that tiny piece instead of looking at the rest of the puzzle, right? So, I just yeah. I don't love that. Now, you did mention whole genome testing on embryos. That's another interesting concept, but I will tell you there's still so many things out there we don't understand. So it's already hard enough when you find anything in a pregnancy, let's say. Let's say that somebody has a piece of a chromosome missing and we don't always know exactly what that will look like. That's
Mm-hmm.
already hard enough. So thinking about how every human carries a handful of variants, well, okay, what are you going to do to make, especially if you only have a few embryos, now you have this anxiety about which one you're implanting. And, of course, if it has a very significant disease, that's different. But usually then that's not whole genome sequencing. That's looking at what you did, PGTM, and looking to see which embryos are affected by the condition that you're trying to avoid passing down. And that I think is just a lot, that's a lot more commonplace and very important. I don't think I don't know. I think we have to get a little further in our understanding of genetics to really be making widespread decisions on embryos based on that. But yeah, so
Yeah, it's like you said, it adds a whole other level of complication and moral choice. And I was really, this is weird to call this lucky, but the embryos that I had that carried my gene mutation, the female embryos, every single one of them also was chromosomally abnormal. And those were not embryos that I would
wow,
have transferred. So I was
wow,
fortunate that
yeah,
I didn't have to make the decision of essentially throwing
yeah,
myself away. Because if my mom did this testing back in the day, I would not exist.
right,
And that
right,
brings its
right,
whole other level of, emotional element to it. But I was
yeah,
very fortunate that I didn't have to make that decision. And
yeah,
then at the end of the day, my husband was just making girls. So we had 3 embryos from that first cycle, 9 embryos from the second one we were able to send off, and we ended up with 3 quote unquote healthy embryos. And like you, I got pregnant the first time with my daughter. I miscarried with the second perfect quote unquote embryo. And
mm-hmm,
then now
mm-hmm.
I have my little girl, Violet, and that was my last embryo. But yeah, it was really an emotional thing for me to have to sit down with my partner and say, "Hey, what do we do in this case? Do we
Yeah,
discard an embryo that is could potentially maybe in some way be affected by this gene condition?" But the answer for
right,
me was obviously yes. That's the reason why I was doing IVF solely, was
mm-hmm,
to make sure that the legacy of this condition in my family died with me.
mm-hmm.
But it it opens up a lot of emotions. Do you
Absolutely. It
see
is
that in
such, yeah.
talking? Yeah, I'm sorry. Go ahead.
Oh, no, it is such a complex, it's so complex because I think, you're right. What you said earlier is that people think of IVF as like, oh, I'll just do IVF. And there's a lot more to it. And there are people that end up with like one like euploid or chromosomally normal embryo, and that has the BRCA mutation, which is what they were trying to weed out. And then it's this like ethical thing of like, do we transfer this? And then some clinics are weird about it. And And so then it's like, well, then do you just try naturally? Do you try another round? It's really hard. And so that's a whole discussion, it's a really difficult discussion, but I think it's like, it's very case dependent. It's very situation dependent, and it requires a lot of therapy, I think. So I think the other thing I recommend for people going through that or any infertility is therapy, like seeing a therapist who understands infertility. That to me made the world of difference. And I've seen it in my friends and in my patients that like a lot of this is very psychologically tolling, and people need somebody who understands that and can talk that through with them.
Yeah, and I think when you're doing this too, you're almost, this is another like kind of crass way to talk about it, but spoiled for choice when having too much information. So
Yeah.
I thought that I wanted boys, and now that I have two girls, I'm like, you crazy. But
Yeah.
I was devastated. The gender disappointment that I had in realizing that I had 12 embryos that went off to testing and 11 of them were female. I just, the likelihood that I was ever going to have a little boy was next to nothing. And that was a whole emotional experience for me, which seems so silly now that I'm looking back. Like, my husband looked at me and he's like, you don't get to play God. You don't get to choose if you do it the quote unquote natural way too. Like, we are doing this to ensure that we have healthy children. Be grateful that we have the potential to have healthy children, but then you're also going through the element of, okay, well, my child maybe doesn't carry this condition, but they might have this condition. Here's the risk for this. And it can just put you down this really rabbit hole of crazy emotion that you never even thought that you would have to manage or knew existed. And then doing IVF comes with its whole emotional element of, well, we're not doing this the natural way. You're losing the romance. You don't get to do it the way that normal people do it, but then you look at all these people that are struggling with, infertility and all of these problems. So, I mean, it's easy to be damned if you do and damned if you don't, I think, in this space.
I will say this. I think parenthood in general, everyone will have a struggle or several struggles that they have to face. And it's not fair many of the times. But my therapist used to say the pregnancy gods are fair. So if one person deals with one thing, another person deals with another thing, there's been a lot of situations where when I was going through it, I was like, oh, I'm so jealous of this girl. She gets pregnant so easily. She's on her third, but then she was like hospitalized the whole third trimester and was like on bed rest in the hospital. And I was like, okay, why was I, so there's always going to be something like that. And then if it's not during pregnancy, it's during early childhood, right? Dealing with delays, dealing with medical issues. So it's so easy to compare, but I think that's the thing is like everyone's really truly on their own journey. There will be emotions, like even the gender disappointment, it's very real for some people and maybe not as much for others who are just trying to have a child. But all of these things, all of these emotions and feelings are valid. And I think just knowing that everybody will face some of these at some point in time, just knowing that's normal,
It's a new chapter for a lot of us who are utilizing different scientific tools to get pregnant, to go through that whole experience. It's just, it's an experience that no other generation has really navigated.
Yes.
We're the first ones to do it. And the same thing with these home gene tests, being able to test for massive amounts of potential mutations and issues. We're the first generation navigating that and figuring out how we feel about it, figuring out what we're going to do about it, and then how do we feel ethically and morally around having that information and that choice. Where do we take it? Where do we draw the line? And, I talk about this a lot on other episodes where in Germany, where I live, the type of gene testing that I did on my embryos is illegal. And so I literally had to cross international borders to go and try to ensure that I had healthy children, which seems like, oh my God, this is such a logical step. Of course you would do that. But the country of Germany has a different history than the United States. And so there's just different conversations around it, and how this is going to continue to be varied across the world, and how we manage that long term.
Yes, yes, that is a huge thing. I think the science has advanced further than our ethical understanding, right? And our ability to, I guess, make these decisions as a culture or society, because there are people that really disagree, and then there are people that disagree with those people. So yeah, I think it's definitely, and then it's also the added stress of, well, I live in a country that doesn't offer this, but if I don't do this, am I a bad parent because I didn't go
Right.
there and did do everything available? And so I think all of this, again, having a therapist to talk through these decisions with is invaluable.
Absolutely. Well, I'm not sure when this podcast is going to drop. We might have to postpone it a week, but I can tell you behind the scenes, the Previver, we are offering the first ever PGT grant for a Previver. So for a
That's
couple that,
amazing.
yeah, it has a mutation, but might not have the financial resources to test for that mutation, we are going to provide that grant for them. So that will launch at the end of this month. And that was such an important thing for me and my sort of lived experience, knowing just how expensive IVF is and PGT. And I had to have all of that out of pocket because I didn't struggle with traditional fertility issues and I didn't have a cancer diagnosis. So there were no financial resources available for me. So I just drained my life savings to have my little girls. And I'm incredibly grateful that it worked out for me. There's so many people out there that do that and don't bring home a baby or don't have healthy embryos. And so if we can eliminate that barrier to entry for somebody, that was very, very important that our organization do that. But it was mind blowing to me in researching this that there is nothing available for somebody out there who knows that they have this inherited condition and they don't want to pass it down to their children. And you spoke a little bit about the guilt that parents have to manage of, hey, we just cannot afford doing IVF and testing our embryos. And are we ethically right in still having children and quote unquote risking it? Do you have a lot of patients that come in with those sort of concerns?
Yeah, yeah. And I think some people do decide to go the non-IVF route and take their chances. It gets really hard because, you have the ability to test at about 10 to 12 weeks with chorionic villus sampling. But then what do you do, right? Like then if you have a baby that's affected, are you going to terminate? Especially if, like you said, you're terminating yourself, right? Like you've lived with this. It's a really, really, really difficult decision to do, to even think about. So, again, it's very situation dependent. And also I love, like I said, I've been saying like the therapy that it really, to be thinking about this for a while, to be confident in the choices you have. But I definitely have patients that will choose all different things. And there are some that are like, I don't even want to bother with IVF. I just want to get pregnant naturally. And we will deal with it when they're older with the hope with the hope that the science and our understanding of these mutations will be so much better in the next 2 decades, right? So by the time that a child is dealing with these risks, we'll have better information, we'll have better tools, we'll have better screening, we'll have better interventions, maybe gene therapy, right? So with I think that that's something that a lot of people really hold on to, is that there's this hope that then the next generation it'll be easier, or maybe even IVF for the next generation will be way more easy to access and just a smoother thing and not be so tough on the body. So so there's a really a variety of ways that people choose to go about this, and I'm supportive of whatever's right for each person because there's no one size fits all approach to this. It's very situational dependent.
Yeah, that was sort of my next thought is, how do you feel about people who don't want to know? And that's something that I've struggled with a lot, being in the personal preventive healthcare advocacy space of knowledge is power, wanting people to know. But there is a large group of people out there that just do not want to know. They're either too scared, they don't care. And then where's the ethical line of, do you test those people if they're not going to take any action? And then you're now burdening them with the knowledge of their risk. And do you see that in the practice where, like, maybe one family member says, hey, I want to be tested for this, and the other one is like, absolutely no way, I don't want anything to do with it?
Absolutely. Every family has somebody that wants to know and somebody that doesn't. My own family has that. I have my mom's cousins have BRCA2 mutation, and it took years for many of them to get tested, and there's still people not testing. And then for my husband has second cousins that have Lynch syndrome, and not all of them have tested. It's there's a variety of reasons why. And I am, by the way, like, I'm a genetic counselor. I talk about this day in and day out, and I still have close family members who have not tested, right?
Does that just make you want to like shake them, or do you have compassion for it?
I have compassion because what I've seen over time is that people need a few different reasons to motivate them to test. So sometimes somebody's saying no now, that never means no forever. It just means that they were not in the right mental or like place in their life where they understood the value, or where they were okay with understanding this information, or they were able to accept this information. And that's okay. So I always tell people, like, you cannot force your relatives to be tested. You can only give them the information for them to make a decision. That is the only thing you do. That is your only responsibility. It is not on you to force somebody. And like I said, like a no now is not a no later. So that's okay. Sometimes it takes people months or even a year or two before they decide to do this. But oftentimes what happens is somebody in the family gets a cancer, and then all of a sudden people want testing, right? Because then it's like a lot more imminent, or it's a lot more.
It's in your backyard now.
Exactly. And so there's this paradox of just being like, oh no, it's not going to be me, or oh, this is probably not that important. But then once it starts to get closer to you and in your life, and you start to realize, oh, this actually is relevant for you, then people are more likely to do it. Those people. There's also a lot of different situations of why somebody, even when they know the information, may not want to. So sometimes, like, people who are in active military duty, sometimes the results can affect your work. And so sometimes there are ways to get around that, or we screen people, like certain federal employees. There's certain really strange, like, random situations where the results could affect their job. And so we may screen them as if they have a condition, and then wait till there's a better time to test them so that there's no record of it, right? So those are like few and far between, but that's something that we help people kind of understand. And then of course, like testing children, for something like a BRCA or some of these other high-risk cancer genes, most of the time they're risk to children. There's no change in medical plan for children. So we're not going to test a child, but a lot of parents will want them to. And so we have this whole discussion about it being up to the child when they're an adult, and they can make a decision, and they can really, normalize that information.
Yeah, that's a question I have. I'm sorry to interrupt you, but is it possible for children now to be tested for these? Because I was tested for my condition very young, probably 8 years old. And now everyone that I talk to has said, oh, well, they won't test until 18. Is that new, or is that very state to state or physician to physician?
What, when you're talking about your condition, do you mean the BRCA or the other?
Let's say BRCA as an example. So yeah. I carry Wiskott-Aldrich syndrome. And my brother and I were tested when we were very young because my mother was a carrier. But now I have not heard of anyone in my circle who's had their children tested for a known gene mutation. It
depends on the condition. So for something like Li-Fraumeni syndrome, like the TP53 mutation, there are childhood onset cancers and cancer risks and things to do that are changing. For juvenile polyposis syndrome, for familial adenomatous polyposis syndrome, there's certain things that would change care maybe. in childhood or in teenage years. And so in those cases, we do offer testing, and it is important to know. But if something doesn't change care until later, then there's not, the only thing it does is cause anxiety or cause, people to just be thinking about it all the time. And so, and then it's kind of, the ethical thought is that it takes away the decision from the person who has it, because they were tested before they really knew what they were doing or choosing. And so there's a lot of just studies showing that it's better to allow the patient to decide when the right time for them is in the long run, rather than the parents deciding for them. So
that makes so much sense. And that makes sense in my case too, because it's almost deadly to children. And so of course, if my brother were to have it, that would make sense. And then they probably just tacked me on as, okay, hey, if you're testing my son, you might as well test my daughter for carrier. That makes a lot of sense.
Yeah. So when there's childhood implications, that's when it's a whole different story. But for things like BRCA and ATM and CHEK2, the only time when we would be worried about childhood implications is if both parents carried a mutation in the same gene. Then it could pass down something. So for BRCA, if two parents both carry, let's say, a BRCA1 or BRCA2 mutation, and they both pass it down, and the child inherits an abnormal copy from both parents, then they can have something called Fanconi anemia, and that has childhood onset issues.
Okay.
And so that would be the only time when we really would test for that. Same with like ATM, there's ataxia telangiectasia when inherited from both parents. And then a few of the other cancer genes also, like Lynch syndrome, if it's the same gene, they would have something called constitutional mismatch repair deficiency that causes childhood cancer. So if that's suspected, or if it's known that both parents carry a mutation in the same gene, then we would test a child. But that's really the only situation with some of those mutations.
I would love to know how your personal experience with your sister has shaped how you counsel patients.
Yeah. Well, I will say, I think personal experience in general, like with everything I've personally experienced, so with having a sister who has a lot of medical needs and disabilities, that alone has made me very empathetic to people with any type of medical needs. But I also, going through infertility, and then I have my own chronic diseases and an undiagnosed disease, so I've been on the patient side so much, and so I really practice with the patient at the center of my mind, like a patient-based practice versus here are the guidelines, this is what we should say. Well, that doesn't work for everybody, right? And if I were the person sitting on the other side of the table, what would I want offered to me? And that's kind of how that's shaped the way that I really practice. And then of course, being a mom has even changed it on top of that. So definitely, I feel like just my life experience has given me a very patient-centered approach to genetics and genetic testing, and to, not being paternalistic, meaning not saying, okay, you shouldn't have access to this because you may not understand it. It just giving information so that a patient does understand, what their options are, and then what the possible implications could be, both psychologically and physically, of learning this information and what our recommendations are. So yeah, I hope that answers that question.
No, absolutely. Has there been a patient story that has changed how you view your work, that has really deeply impacted you?
There's like a number of them. I think that there was one case once where I had a patient who didn't take out Social Security or any long-term finance options, because she was so convinced that she was going to end up the same way as her mother and grandmother who had cancer. And I didn't realize how deeply ingrained that was in her identity. The fact that she didn't save money and she didn't have kids because of that. And so when we found out that her results were negative, she told me the next day that she and her husband decided to have children. And that was whoa, that was so deeply embedded in her identity that she was going to end up this way, that when we actually talked about this and she realized, oh, I actually might have my whole life ahead of me, that it shifted so much. And so I think that that's one example of how it's like, wow, okay, this is really important. Even if it's just for, like, a negative is just as important as a positive result for some people. So that's
Absolutely.
something I always remember. Yeah. Because there's a lot of guidelines in the field where it's like, well, why is this going to help this person? How is it going to help? And I think the psychology and anxiety and identity shift that comes with a negative result is just as important as the positive in some cases.
Absolutely. This reminds me of when I had shared my IVF experience online, and I was very open with all the nitty gritty when things failed, when things went right. Talked about PGTM, and you go into content creation where you're talking. I know you handle this all the time. Scientific things. You don't know if people are going to relate to them, if it's going to hit the right audience. And I had a girl write me, and she said, I carry BRCA, and my husband and I decided not to have children because it wasn't worth the risk. And I did not know that PGTM existed until I saw your silly little Instagram post.
Oh,
And
oh,
it makes me, I'm like tear up now, like tear up all the time, because she said, my husband and I can have a family now. And they do. They have,
oh
I
my
think, two little
God.
babies
Yes.
now. And it just shows you the power of social media, the power of sharing
Yes.
information. And I want to thank you so much for what you do, because there are so many physicians out there spreading misinformation, science
Yeah.
experts, quote unquote. And for you to go out and share this information and let people know that these things are available and that it doesn't have to be hard to digest. They can learn
Yes.
about their
Yes.
options. You can dip your toe into it. It doesn't have to be scary, because when you're armed with the information, then you feel empowered in the decision-making process, and knowledge is power.
100%. And I can tell you that most of the time anxiety stems from uncertainty and the lack of information. And when people get it, it actually helps lower anxiety. Even if it's scary information, it's still information that they can then feel more control over. So that's a big thing to remember, is that a lot of times information can really give someone a sense of control and power that they didn't have before. And I love that story, because I think you're right. I think every single post, especially as someone who's like posting all the time, just like you and a lot of other people that are sharing their stories, a lot of times it's like, oh, this post didn't get a lot of engagement. And it's like, oh, that's a bummer. I spent a lot of time on this. But as long as it hits one person that then finds that out, like you said, and then completely changes her life trajectory, that is like my North Star for creating content. And my favorite messages are when people say, I saw your story. I didn't realize I could get genetic testing. I went and asked my doctor. I used the script, because I have some where it's like, here's what you can say if they deny you the scripts. And so they would be like, I used this and I got testing and I found out I had a mutation. And now like the whole family, can be helped by that just from one video. So I think the impact we have, and that's only if they share with us, right? Like imagine how many other people that didn't share with you, that may have scrolled, saw a video, didn't register who you were, but they got the information from it and it was able to change their lives. So I think the cascade effect and the impact that we have by just creating this content is so strong. And that's what keeps me going with all of it.
Absolutely. I had one woman who wrote me, and she said, it was so funny. I'm opening this message. She goes, I really get annoyed by your stupid self-exam gram, but like learn how to do a self-exam post every month and reminding me that I have to do this. She's like, because it is like looking in the mirror and I'm remembering, oh God, I don't do this. And she's like, you're guilt tripping me. And she goes, but I saw your post, and for whatever reason, I'd been putting off my mammogram and I just decided to schedule it. And she goes, I just found out I have early stage breast cancer, and this might have saved my life. And her just opening up with, I hate your stupid little videos. And that's how I feel sometimes. I'm like, God, I'm putting out these stupid videos. Nobody's listening, but you just don't know. And so for all the listeners out there who might, think, oh my gosh, my audience is small, I'm not impacting somebody, I always tell them, you don't know whose life you can change sitting at a airport bar, talking at the PTA meeting. Like, share the information, put it out there.
100%.
And
even if you have 10 followers, like 10 people hearing a message
Yeah.
one of
Can you
those
imagine 10 people in a
making,
room listening
yeah,
to you? Like that's a
yeah,
panel, you know? So it's easy to get like trapped in this idea of like the numbers game. You see other big creators, you see other
yeah.
people that feel like they have a bigger platform, but if you got 50 people in a room listening to what you have to say, that's a lot of people.
It's a lot of lives you can change. Even with like one little nugget of information, it could plant a seed that then down the line really changes their whole trajectory. Yeah. Yeah.
Totally.
Definitely.
Well, this is the Learn Too Late podcast. So, what's one thing that you feel like you learned too late in life? And this can be science related, genetics related. It can be anything in your life. What did you learn too late in life?
Oh my gosh, that's so funny. I think this is going to be so random.
I love it. The more out there, the better.
So I think not sleeping with makeup on, because I used to do that in college all the time and then developed a dry eye condition because like all of it got stuck in my eyelid and stuff. So now I have to practice a lot of eye care and like get a lot of treatment for my dry eyes. And I can't get LASIK because I've had ulcers on my eyes. So I think that's
I
something
love
that
this.
is too late. Yeah, is that like don't sleep in makeup and like wear like don't use the stuff that might be dirty because eye infections are really can happen really easily. Um, yeah, I mean, I think that's a big one for me.
Well, I
Yeah,
love that. So, anybody listening, take your makeup off
yeah,
before you go to sleep. And
hmm
if you are noticing any sort of patterns in your family with cancers, with certain conditions, go see a genetic counselor and,
yes.
maybe call Dina
And
up.
I'll give you a website. So there's a website called findageneticcounselor.com by the National Society of Genetic Counselors. There's also a version in Canada, and there's versions in other countries. And so on my Instagram, like my link tree on Instagram and TikTok, I have the links to those so you can find one near you. And then I also have my private practice, so you can after my maternity leave, you can come see me if you would like an appointment to talk about this.
I love to hear it. Thank you, Dina, so much. This has been wonderful. It has been informative. And yeah, I will add everything in the show notes where they can go and find you. And good luck on maternity leave.
Thank you.